Good afternoon, everyone, and welcome. On this wet day, I'm really pleased that you've all made it a priority to be with us this afternoon and hear our Tarjan Center distinguished speaker, guest today. My name is Olivia Rayner, and I direct the Tarjan Center at UCLA, which, as many of you know, is our University Center for Excellence in Developmental Disabilities. On behalf of the Tarjan Center and our co-sponsors, the Center for Autism Research and Treatment and the Intellectual and Developmental Disabilities Research Center, I want to welcome you to this afternoon's lecture series. Our speaker is Dr. Charlotte DiStefano, and she is a clinical instructor in the UCLA Department of Psychiatry and Biobehavioral Sciences and a clinical psychologist with expertise in autism spectrum disorder. Please welcome. Come on in and take a seat. And I digressed, I'm sorry. Dr. DiStefano is a clinical psychologist with expertise in autism spectrum disorder and related neurodevelopmental disorders. After receiving her Bachelor of Science in Special Education from NYU and a Master's in Mind, Brain, and Education from Harvard University, Dr. DiStefano received her PhD in Psychological Studies and Education from UCLA. She completed her postdoctoral training here at the UCLA Center for Autism Research. Before earning her PhD, Dr. DiStefano also worked as a special education teacher with children with autism in both New York City and Los Angeles. At present, she is an attending in the UCLA Child and Adult Neurodevelopmental Clinic and the UCLA Developmental Neurogenetics Clinic. She provides assessment and evaluation of children with ASD and related neurodevelopmental disorders, as well as treatment consultations regarding language and communication development. Dr. DiStefano's primary research interests focus on language development in minimally verbal children with ASD. She was awarded a Mexner postdoctoral fellowship in translational research from Autism Speaks to identify EEG biomarkers related to language and literacy abilities in minimally verbal children, and serves and with the eventual goal of informing treatment decisions. Currently, she serves as the UCLA site coordinator for a multi-site NIH Autism Biomarkers Consortium for Clinical Trials Research Study. Today, she will be presenting what promises to be an interesting and informative lecture on minimally verbal children with ASD, understanding their abilities and development. Please join me in welcoming Dr. Charlotte DiStefano.
Thank you. Thank you, guys. Very excited to be talking to you today. I realize as I'm standing here looking at this slide that the title is already sort of misleading. What I'm going to be talking about is how we're trying to understand their abilities and development. We certainly do not yet. So I'm not going to be revealing anything magical, but I'm going to talk to you about how we're trying to understand these things and why we're trying to understand them. As you heard, I am both a researcher and a clinician, so this talk is going to be structured to talk about a lot of the different research I work on, but also sprinkled with a lot of my clinical thoughts as we go through. Hopefully that will be interesting to you guys. I know there are a lot of parents and other community professionals in the audience. I'm also happy to answer questions as we go through, as long as we don't derail too much. So if you have a burning question, please raise your hand as we're going through. Okay, so here is my possibly too optimistic goal for today. We're going to talk about what I mean when I say minimally verbal. It's a term that's starting to be used more often. I want to make sure we're all on the same page about it. I'll talk a little bit about what we know about predictors of language outcome in general in ASD. We'll talk about what we've been able to learn so far about abilities and variability within the minimally verbal population. A little bit about assessment and intervention strategies, and then I'm going to end by talking about novel methods for measuring abilities, specifically work we've done with EEG, trying to help us understand minimally verbal kids. All right, so depending on which estimate you're looking at, about 25% of school-age kids with ASD are what we would call minimally verbal. This number used to be more like 50%, and it's coming down as kids are getting more and more access to early intervention. So hopefully, you know, kids who are just being diagnosed now, we might not still be at 25% by the time they grow up, but these are our estimates for now. Intellectual disability is not the same as being minimally verbal, as I'll show you in a minute. Estimates of intellectual disability within autism in general vary really widely, depending on how you're measuring it and what cohort you're looking at. And it's been estimated at anywhere between 20% and 70% of kids with autism meet criteria for intellectual disability. And so it's important to realize that these are two separate constructs, and we sometimes have a very difficult time pulling them apart, but I'll show you a little bit of why I think it's important to consider those things separately. And then there are many neurogenetic syndromes that are associated with ASD that include significant language impairment. So for example, we've done a lot of work with kids who have DUP15Q, and I'm not going to be talking about that today, but that is another area with a lot of overlap. So when I say minimally verbal kids, this applies to kids who have no language at all, or kids who use some single words, maybe even short phrases, but they're quite inflexible, they're restricted in context. These kids may be able to use language in a highly familiar situation, but they're not going to be able to flexibly express themselves to you. It's worth thinking about at what point we start identifying a child as being minimally verbal versus pre-verbal. There is enormous variability in early language development in ASD. The average age of first words in ASD, this estimate is a little old now, but was 38 months. That might be a little earlier now. But these are kids who, on the whole, are delayed in attaining language. More recent estimates, 50 to 70% of preschool kids with ASD have not yet attained phrase speech, but 70% of those kids will have phrase speech by the time they're 8. So just because a child hits preschool and isn't talking or isn't using much language yet doesn't necessarily mean that they are going to be minimally verbal. There's still a lot of variability. And at the individual level, we are not great at predicting who is going to remain minimally verbal and who is going to develop lots of language in the coming years. So it's important to realize that we don't know the answer to that early in development. We used to, as a field, think that language by age 5 was really a very important prognostic indicator. If you were talking by 5, great, and if you weren't, that was probably where you were going to be. And although the age at which you start speaking is still an important predictor of how things are going to go in the long term, we know now that this is not such a hard and fast rule the way we used to think about it. There are a lot of kids who have not gained language by age 5 who do still develop language afterwards. So we certainly want to be really focused on this if kids don't have language by age 5, but we don't think the door is closed to developing language. When I see families in the clinic, I often see families who have a child who's nonverbal or minimally verbal, and they're in that 3, 4, 5 age range. And the most common question I get from parents is, will my child learn to talk? When will they learn to talk? How much language will they have? How do we know what's going to happen? We don't, as I said, we're not great at predicting for an individual whether or not they're going to develop language. There is a decent amount of research on predictors of language outcome in general in ASD. So we know that if the child uses joint attention, if they use gestures, their level of motor skills, their ability to imitate, their nonverbal cognitive ability, and just the range of vocal sounds, how many different vocalizations they're producing, all of those at the group level predict to better language outcomes. So if I see a child and they're using lots of joint attention, they're gesturing to communicate, they're making a lot of different vocalizations to get my attention, they're able to imitate me, I don't know for sure what's going to happen, but I can tell the parent at least these are some positive signs that I think this child might be on this path. If a child is not using these types of skills yet, we want to address them because we think that's really going to help the child then be able to develop language later on. And I'll talk a little bit coming up about intervention that targets these pre-linguistic skills. And then we think about, clinically, we just think about, is the child still on a developmental trajectory, or are we really seeing a plateau? If the child has gained maybe 5, 6 words, and now it's been a couple years, and they haven't gained any new words, and that's just kind of where they're at, then we might start to think, okay, this might be the limit of their verbal language. What other ways can we get them to communicate? But if they're adding sounds, adding words, adding new skills, just doing it slowly, then we have no reason to believe that they've stopped developing language. It seems like that's still slowly going on, and we want to give them time and see what's going to happen. Yeah?
When you say that about language, is that just spoken language, or does that also include like sign language?
I'm talking here just about spoken language. Sign language, in terms of thinking about it developmentally, would count as a gesture. So it's a really good sign if a child is using sign language communicatively, just in terms of their potential for future communication. For any of you who are speech pathologists in the audience, this is an article that Connie Kazari and I wrote for ASHA just about this issue that I was just talking about, of trying to figure out if a child is pre-verbal, if they're minimally verbal, and do we really need to target different types of non-vocal communication, and when are we going to make that decision? All right, so I'm going to talk a little bit about data from one of our studies. This is the same study that I just showed you the video clips from. So this is that population of kids. And don't worry about all the details, I just want to highlight a few things. So this was a study of 61 minimally verbal kids with ASD between the ages of 5 and 10. And we defined minimally verbal based on the number of words that a child used on a language sample. And so it was a 20-minute language sample, and if the child used fewer than 20 different spontaneous words, they were classified as minimally verbal. So for our purposes in this study, that's what we're talking about. And I just want to highlight the range of abilities that we see here. So for those of you who are familiar with assessment, we used the TELD as our measure of expressive language. For those of you who are not familiar, it's not that important. And most of these kids were not even able to achieve a score on this test. They couldn't do even the first couple items to get a score, a third of the participants. And then the other third were able to get a tiny bit of a score, but they're overall at an age equivalent of 1.7 years, and these are 5 to 10-year-olds. So really impaired in terms of their expressive language. But another thing that we measure on our language sample is not the number of different words you use, but just how often you use those words to communicate. And it can be ball 15 times if you're really asking for the ball or commenting on the ball all 15 of those times. And so we counted the number of, again, spontaneous communicative utterances in this 20-minute language sample. And we have kids who never used a single communicative utterance and kids who did 124 times in 20 minutes. So there's a huge range in terms of how much these kids are attempting to communicate, even though they're universally working with a very limited set of language. Their receptive language also ranges a bit more than their expressive language, from 1.9 years age equivalent to 4.7 years, so below their chronological age, but still a pretty big range there. And then I really want to highlight, back to the intellectual disability question, nonverbal IQ in this sample ranges from 36 to 123. So for anyone who's not familiar with IQs, 100 is average and 123 is 1.5 standard deviations above the average and is quite a high nonverbal IQ. So certainly it would be hard to make the case that a child with a nonverbal IQ of 123 has intellectual disability, despite the fact that that child, if you measured their verbal IQ, would be performing very low. So we really need to think about what intellectual disability means in this population and make sure that we are appreciating this range of abilities. A child who has a nonverbal IQ of 36 is probably very challenged in a number of domains. And in addition to not having spoken language, they're probably having a difficult time with learning and development in general. Whereas a child who has a nonverbal IQ of 123 is similar in terms of their spoken language profile, but clearly something different is happening for that child in terms of why they're not developing language. So I think it's very important to think about these other abilities and not lump minimally verbal kids all into one group. And then we also saw huge variability in their ADOS severity, the amount of repetitive behaviors they showed. And this is one of the reasons why I really, really prefer the term minimally verbal to low functioning. Because if we think of all these kids as just severe autism, that again is not accurate. Our ADOS severity is our measure of autism severity. That scale ranges from 1 to 10, 10 being the most severe. And we have the full range there. So these are not kids who are all showing the full range of most severe autism or getting the full range. Okay, and just to quickly highlight that we can see the same thing in very large data sets. We started looking at the Agree database, which is a nonprofit registry of genetic and phenotypic information from now over 1,700 families. This was started by Cure Autism Now and is now run by Autism Speaks. And I looked at 5 to 18-year-old kids in the Agree database who had scores for the assessments I was interested in, which was a total of about 1,500 kids. And for this project, I was interested in how we define being minimally verbal and how that changes the kids that end up in that group. You don't have to worry about that part. What I really want to highlight for you is that regardless of which assessment definition we chose, this is nonverbal IQ score on this axis here, and these groups are all including kids who have quite high nonverbal IQs. So no matter how you define the groups, even with our most stringent definition that ends up with only about 12% of the kids being identified, even they include some kids who have average IQs, nonverbal IQs. So it's not a fluke that we had a handful of those in our study in Connie's lab. This really seems to be a consistent finding. So hopefully I've convinced you that minimally verbal kids are a really varied population. They can use a variety of resources to engage in communication. Nonverbal does not mean non-communicative. And I think sometimes in an effort to improve a child's spoken language, we sometimes focus a little too much on just their spoken language without appreciating the other things they're doing to engage in communication and supporting and developing those as well. If a child is capable of developing a spoken language, I really, really want them to do that. But if they're 8 years old and they have limited spoken language, it's not because they're being stubborn and they just don't want to talk. They're really having a hard time producing language. But if they're using gestures or they're using a speech output device or they're using sign language, I want to support that while we're also continuing to support any spoken language development that they're capable of. And we also know that these kids can change over time, and I'm going to talk a little bit now about progress with intervention and some of the research that's being done. When I was in grad school here with Connie Kassery, I worked in intervention research, and I work in intervention now clinically, but I no longer do intervention research on my own, so I'm going to be talking about other people's work for a few minutes here. So we now have a nice set of evidence showing that minimally verbal kids demonstrate increased spoken language with intervention that targets actually pre-linguistic skills rather than directly targeting the language itself. So there's a study looking at combining PECS, Picture Exchange Communication System, with pre-linguistic milieu teaching, which found increases in spoken language, even though they were not directly targeting language in that study. There are quite a number of studies from Connie Kazuri looking at Jasper, which is the intervention she has developed, which I'll talk more about, which targets prelinguistic skills. And then the Early Start Denver model is the other big intervention program that is building up a pretty decent body of research to show that targeting prelinguistic skills helps you develop spoken language. The big foundation of a lot of these intervention programs, and Jasper specifically, the JA in Jasper stands for joint attention. The big foundation is that there is a very powerful relationship between joint attention and language. So joint attention is the active coordination of shared attention between a partner and an object. So we're all jointly attending to these slides right now. I can talk about these slides, and I know that you're also looking at them and will know what I'm talking about, as we're jointly attending to the same thing. In this picture, this little guy is holding up his blocks, and Mom and I, totally not scripted, spontaneously both pointed to them at the same time. We're all focused on the blocks. And this is something that typically developing kids do naturally and effortlessly. And if you don't think about it, you don't even realize it until you spend some time with kids who are struggling with this. And then you see a typically developing toddler and you realize, oh, they're doing this constantly. It predicts language, specifically symbol-infused joint engagement, which just means that we're jointly attending to the blocks and talking about them. And the amount of time you spend doing that is a huge predictor of language. How many of you guys have seen those First 5 LA commercial campaigns about how you should spend time talking and singing and reading with your child? That's because symbol-infused joint engagement predicts just about every good thing in development. It's just incredibly foundational. And so Connie and others have developed interventions that really try to leverage this idea, and Jasper has been quite successful. And so her intervention found that increased play and joint attention initiations come along with increases in expressive language. And she's found this specifically in minimally verbal kids. So in this intervention, we focus on developing play routines with the child, trying to increase the amount of time that we're jointly engaged, using joint attention gestures like pointing or showing something. And then the adult models language in those jointly engaged states and gives opportunities for the child to communicate in those same states. And that seems to lead to increases in spoken language, even though we're never specifically prompting and demanding that the child use spoken language. So it's kind of counterintuitive if you come from that background, but I think it's an important thing to consider. So I'm just going to highlight this quickly, and someone asked me if I was going to talk about AAC devices, and this is where I'm going to talk about it, so raise your hand if you have a question before I move on. So the details are not that important. There were 2 conditions in this study. Everyone got Jasper, and then half the kids, we also used a speech output device incorporated in the Jasper session, so that's the plus AAC. So the important thing here is that all the kids were communicating and talking. This is just spoken language. All the kids were communicating more often over the course of intervention, and the kids with an AAC device had this really nice quick increase, and we're not counting aided language, this is just actual spoken language, had this really quick increase, and then by follow-up the groups were not as different, so they sort of increased more quickly and then stayed level. I was interested in looking at a broader definition of communication, not just spoken language, but back to that idea of anything the child is doing to communicate. Gestures, vocalizations, broadening it out. So I looked at communicative interchanges, which you can think of them as a proto-conversation, where the child and adult were going back and forth, and the child was doing anything to make a communicative term. And we found that the number of interchanges went up over the course of intervention. The kids who were using an AAC device were going up at a faster rate. And then if we looked at who was sort of responsible for these increases, we broke it down by whether the adult initiated the interchange or whether it was the child who took the first turn. And you can see that the adult initiated interchanges stayed at the same level. It was really the child who was initiating more and more over time, which is exactly what we want to see. So these kids were not fluent speakers by the end of a 6-month intervention, but they were communicating more. They were using more spoken words, and they were communicating more independently, initiating, which is what we really like to see. So one of the things that I do a lot as a clinician is work with families who have a minimally verbal child who want to know, how do I start using an AAC device? I am not a speech and language pathologist. For those of you in the audience who are, I'm certainly never claimed to be, but the reality is it is hard to find community providers who are good at using these devices with older minimally verbal kids. There are a handful of them, and I refer to them all the time, and if you are one and I don't refer to you already, please let me know. So I end up working with families a lot to just say, okay, you have not been able to find a speech and language pathologist who wants to work with your child on this. Maybe the school told you your child's not ready for it, they're too impaired, they're not going to be able to do it, and the parent wants to do it themselves. And so what I do is talk to parents about strategies for trying to introduce an AAC device, because you can just get an iPad now and you can put a program on it, and parents want to do it themselves at home. And so I always recommend that they find a professional to be working with them, but if they can't find one, I don't think there's any harm in giving it a try on their own. So the things we need to think about are, does the child have sufficient motor skills to touch and release the touch screen? It can be kind of tricky, especially for our kids who have neurogenetic syndromes who don't have great motor skills, and so we need to think about whether or not that's going to work. Do they have the visual discrimination to be able to see the different pictures on the screen and tell the difference? We need to make sure that the screen is set up so that it's at the right level for them. Do we want to start with just 2 pictures? Do we want to start with 20 pictures? Do they understand just basic cause and effect? Do they know that I touch this and it makes a sound and you respond to hearing that sound? We need to make sure that they understand that sequence. And then what's their level of symbolic representation? Any of you who have seen these systems know that sometimes they're kind of esoteric, strange line drawings. And we don't want to start with that as the default if we're not sure that the child can understand that yet. So we can use photographs. You can pull other pictures off the internet and put them on there. You're not married to the icons that come with the system. That has to be a conscious decision that you think those icons are a good fit. We really, really want to make sure that we're introducing it at the child's level. If we introduce an AAC system that is way too confusing for a child, then of course they're never going to use it and we're not going to have any success, and we're going to end up concluding that it didn't work and the child can't use a system. But if we pare it way, way, way back and make it something that is easy for them to understand and use, then maybe we can get some traction, get them to start using it, and then make it more complex over time. So when I'm talking to parents who are trying to do this on their own, I recommend that they default to something that they think is too easy rather than something that might be too difficult. If it's too easy, the child's going to show us pretty quickly, hey, this is easy, I got it, and then we can start expanding it. Using a speech output device or any sort of augmentative communication does not impede spoken language development. There are quite a number of studies now that demonstrate this. This is still something that people are concerned about and something that providers in the community will bring up. It does not impede spoken language development. If anything, it augments spoken language development, as we saw. Child starts using an AAC device and they start producing spoken language more after a while. I also like to talk about the difference between communication development and speech development. If you're typically developing and you start learning to talk, you're going to be doing both of those things at the same time. Your communication is going to get more complex as your speech and language gets more complex. If you are stuck with your spoken language and it's not getting more complex, we don't want that to limit your ability to learn to communicate. We don't want your speech to constrain your development of communication ability more broadly. So if we give a child other ways to communicate, they're going to develop more advanced communication skills, and then if the speech starts coming along, great, that can map on to those now better developed communication skills. Yes?
So how do you motivate a kid with an AAC device, but never, ever initiate using that device to begin with, talk to you?
Yeah.
Instead, just make a vocalization, and adults immediately come to his rescue, whatever he wants.
Well, the adults have to stop immediately coming to his rescue then. This can be a big change for families to think about trying to incorporate this, and it can feel overwhelming. My usual advice is to just identify a couple times a day where you feel like this would be the most useful and the easiest to incorporate. You don't have to go from 0 to 60 right away. You don't have to be incorporating it all day. Maybe mealtime is a good time. You know what you're going to be serving for dinner. You can have it set up with a couple pictures on there. You can make it available, have him tell you what you want for dinner, and that's perfect. That's all you need to do for the day. Just start exposing the child to it in those relatively low pressure, easy situations. And then once it's established there, we can start slowly moving it out. Yeah?
I just have a question about, so a lot of people tell me to do like a multimodal approach with all of like using any kind of communication, whether it's the iPad or the like sign language or if it's verbal. What are your thoughts about that? Because I have a child that's nonverbal and I do all of those things, but I find the only drawback with the iPad is like a lot of his other providers are afraid to use it. And B, it's really hard to use when you're out.
Yeah. I think I could talk for a long time about this, so I'm going to be quick and we can talk more at the end. There is nothing magical about using an iPad for communication. I think for a lot of kids, it ends up representing a good avenue for communication and helps them develop skills. But if it is not helpful in your life and your child's life, just given whatever constraints you have, don't feel like you have to make this work. What you want to do is think about what ways your child communicates and how you can build on those. And it may be that this ends up not being the best fit or is only the best fit in certain situations and never really gets beyond that. And that's not bad if that's what turns out to happen, as long as your child is developing some sort of conventional communication. And it may be that in a few years you revisit this and it's a much better fit at that point. So I think sometimes people feel a lot of pressure to make certain things work. And if it isn't working, then we should probably back up and figure out if there's a better plan that will work better. I said better like 6 times in that explanation, but hopefully that was helpful. Okay. In the interest of time, I'm going to skip over this next section real quick. If we have time at the end, I'll go back to it. Okay. I want to talk just very, very briefly about how we measure progress in this population. And I think this is relevant to both the researchers in the audience and people who are parents, clinicians. All of us are interested in standardized ways to measure progress that we can really objectively understand. A lot of minimally verbal kids perform at what we call the floor on standardized assessments, meaning that they can't even get past the first percentile. They can't do the first few items, and so they're always going to have the same score, whatever the floor of that assessment is. If the lowest available score is 20, they're all going to score at 20, even though they're not all doing the same thing. And so we're losing a lot of information there. The other issue that we want to keep in mind is that because of what standard scores mean, the way they're calculated. Standard scores are likely to stay flat or go down over time for our population of kids, even though the child is learning skills. And this is, I think, something that for some reason people are not explaining well to parents when they're giving assessment results. I've had a lot of appointments with parents where they show me, you know, well, his score was 50 3 years ago and now it's 40. I don't understand. Why has he gotten worse? It doesn't mean that he got worse. It means that he's not on the expected developmental trajectory. So if you're a typically developing child and you have age-appropriate language at age 5, your score is going to be 100. And if you have age-appropriate language at age 10, your score is still going to be 100, because that's what a standard score means. It tells you where you are at in relation to your same age peers, and we expect those scores to stay basically the same over time. So for our kids who are not on a standard developmental trajectory, that score going down over time does not mean that they're losing skills. It means that they're developing at a slower rate of development than a typically developing child. And it's amazing, when I tell parents that, they all go, oh, well, of course, I knew that. And so, you know, I really want for you guys to make sure, if you are the parent, make sure you understand this. If you work with parents, please make sure they understand this, because it's brutal to see these numbers go down over time and not realize what that means. So just as an example here, this is a kiddo who we assessed with the same assessment at 42 months and 68 months of age. If we look at standard scores, this child is performing at the floor of the assessment on both time points. They're getting the lowest possible score because they're quite far away from chronological age expectations. And so if we just looked at those scores, we would say, well, the child can't do anything, and they also haven't changed over time. But if we look, for example, at the age equivalents, we can see that there have been changes over time, not age-appropriate changes, not, you know, chronologically the same number of months, but quite a good amount of change. So visual reception, which is sort of a proxy for nonverbal cognitive skills, went from 17 months to 25 months. It's a really nice increase. That child has really learned a lot of skills. And so these are the numbers that we want to be looking at. And every report is going to include the standard scores and the percentiles, because we just have to put them in there. But those are not the numbers that are giving you this sort of detailed information. So this is where EEG comes in and how I transitioned to using this as a research methodology. And I'm going to go, in the interest of time, I'm going to go quickly through sort of the hardcore methods part of this, but feel free to ask questions at the end. So EEG is a great technology because if we compare it to other imaging techniques, it's easier on the kids. You don't have to go into like an fMRI scanner. It's certainly hard for some kids to tolerate the net, but relative to other things, it's easier. And we do have quite a lot of information about what sort of typical patterns are in typically developing infants, toddlers, and young kids, so we can use that to try to understand kids who are not developing typically. So it's just a readout of the electrical activity from the brain, which happens when a whole bunch of synapses fire together, and then that generates enough electricity that it can be picked up by the sensors and amplified. I'm going to talk about an ERP paradigm, which is an event-related potential, which just means that there's a time-locked response to a specific stimulus. So we expose the child to something, they see something on the screen, and their brain generates a response time-locked to that stimulus, so then we can look and see what that pattern is. In terms of speech processing, there is an ERP response called an N400. It happens about 400 milliseconds after the stimulus that relates to semantic lexical processing. So if things go together, if you're expecting to hear a certain word, you don't get a big N400. If it's unexpected, it doesn't match the stimulus that came before it, then you do get a larger N400. And so it's an index of that additional processing. It's basically the brain saying, wait, hold on, that was not the word I was expecting. Let me go back and figure out what word just happened. And so it's been recommended as a way for assessing understanding of language in individuals with limited speech. If you're generating an N400 when a word doesn't match the context, by definition, you had to have understood the word. Otherwise, there's no way for your brain to realize that it didn't fit. So it's not like a beautiful one-to-one correspondence test where we can say, well, he had an N400 apple, he recognized apple. But if we average enough trials together, we can just at least get a sense of, was the child showing this in general to these simple words? So in this study, we were looking at this ERP correlate of lexical semantic processing in 2 groups of kids with ASD, verbal and minimally verbal, and then a typically developing group. So the way this worked is the kids saw a picture on the screen, and then they heard from the speakers a word that was either the correct label for the picture or an incorrect label for the picture. And so again, we're expecting that when this incorrect word happens, there should be an N400, and when the correct word happens, we shouldn't see that peak. But that, of course, can only happen if you understand the word. So here's what we got. I want to make sure I leave time for questions, so going quickly here. So our typically developing kids are on the top, and then these are our verbal kids and our minimally verbal kids. So the black line is when the word matches the picture, and the red line is that mismatch condition. So you can see for all 3 groups, we're seeing a gap between the black line and the red line. It's bigger in the verbal kids, which makes sense. We know those kids are understanding language, so it's not a surprise that their differentiation is larger on average. Statistically, when we look at just the group comparison, all 3 of the groups are showing a significant difference between those lines in this first region, 400 to 600 milliseconds that we're calling the N400. And then in young kids, it's common for there to then be a long negative component after the initial peak of the N400 that is indexing. Basically, the N400 is sort of the initial, I realize that word is different, and then the longer negative component is then integrating that new information with the lexicon, with your mental representation of that word. And in that case, we have the typically developing kids continuing to show this really big differentiation, which is them continuing to process that information. And in our minimally verbal kids, we're not seeing that big differentiation anymore. Our verbal kids, you can see it a little bit, but it statistically is not significant. So it seems like overall, our kids with ASD, including the kids who are not talking, are showing some evidence of lexical semantic processing. They're understanding enough of the words that statistically, on average, those lines are different from each other. But where we see the really big difference is that in the typically developing group, there's this long processing that's happening. And in both of our ASD groups, we're not seeing that later processing. What we didn't find was a systematic difference between the verbal kids with ASD and the minimally verbal kids with ASD. You might expect that the kids who are not talking would show less EEG evidence of semantic processing, and the kids who are talking would show more, but that isn't actually what happened. Instead, we see a lot of variability within both groups, which to me suggests that there are a lot of different ways that kids with ASD come to either develop language or not develop language. Some kids with ASD are able to develop language even though they're not doing a good job with this type of processing. Some kids with ASD are doing a good job with this type of processing and are still not able to develop language. So this is just one little piece of all the things that might be contributing to the different language trajectories in ASD. So this is just the very beginning of doing this kind of work, but this is what we're continuing on with and hoping we're going to find more relevant information here. And this article is under review right now, so hopefully will be out soon if you guys are interested in learning more about it. So the bottom line that I hope you guys take from this is that minimally verbal kids are a really heterogeneous group. They're not just low functioning, they're not just kids with intellectual disability, they're not just kids with severe autism. The only thing they have in common is that they're not talking, but everything else varies substantially. They do make progress with appropriate intervention. Communication can progress even without speech. And if we give them enough opportunities, we can be really, really surprised by what they're capable of. And we need to, I think, be a lot more systematic about giving these opportunities so that more kids can develop like Joseph has. We really need to be very thoughtful about the type of assessments we use to characterize their abilities, especially if you're someone who is interested in doing research with this population. You're going to have to really think outside the box to make sure that you're capturing their abilities appropriately. And novel methods like EEG and eye tracking can help us understand more about the mechanisms of language impairment. And for those of us who work clinically with families, we want to make sure that we're helping families advocate for services and set high expectations for their kids, and be able to really advocate for getting more speech therapy, using an assistive device, having academic goals in their IEP, making sure that they're getting these opportunities. So I'm going to stop there. Does anyone have questions? Yes?
Two, if I could.
Yes, if they're quick.
Sure. The first of which is, do you see any difference in effectiveness of interventions or techniques towards gaining communication or language based on gender?
That's a good question. I have never specifically looked at that. I would guess that there is some research that has, but I'm not aware of any sort of systematic finding.
Okay. Part two.
Yeah.
So you, in one of your slides, you spoke specifically about how AAC devices do not impede the acquisition of verbal language. And that it's been demonstrated, and there was a study that you participated in or authored or...
Yeah.
Okay, and that was dated 2014.
Yes.
The latest one was 2014, so like half a decade ago. Yeah, so 5 years ago.
Yeah.
Is there any concerted effort or program to transmit that information to sort of the larger pertinent agencies? I can tell you from anecdotal and firsthand experience that LAUSD, largely their ideology is we are very reticent to introduce AAC devices because we feel in our gut, viscerally, that it interferes with the development.
I know.
And yet apparently there's data that contradicts it.
Yes, and I am being recorded, so will not give you my unedited opinion. But I think as researchers, we obviously have an enormous obligation to try to get information out there. I think agencies also have an obligation to acquire and listen to information. And some very large agencies, the gap is larger. It takes them longer to adapt to information that's out there.
Is that on purpose?
No, I don't think so. I think it's just you have a large distributed structure and it takes longer. There are a lot of implementation science people who specifically study this. And there are numbers out there, about the research to practice gap and the fact that it takes like 20 years for things to go from being established in research to established practice. And yes, we need to be doing a much better job of it. If you have thoughts on how to accomplish that, please let me know. But I agree that it's frustrating and infuriating. Yes?
Yeah, has there been research done on the difference between intrinsic rewards, for example, with games and music for speech development, as opposed to what you've presented? And that's the work that we've been doing that I presented to you.
Right.
With game and music to help develop, there's an emotional engagement. But has there been studies done to compare that with other interventions?
I don't know exactly. I would guess there's a lot of the applied behavior analysis world does quite a lot of single subject research design, and there's a ton of research out there on reinforcers and motivations and, you know, internal reinforcers versus external. So I'm sure there's a lot of information in that context that, even if it's not looking at these intervention programs specifically, could be relevant for that question. Yeah.
Great, thank you.
Did you have a question?
I did, two also very short questions.
Okay.
First of all, you had to skip over some slides.
Yes.
Is it possible to get a copy of this presentation?
Yes, I think so.
Will you post them on, if you allow?
Yes, I'll remove the videos of the kids, obviously, and then yes, it'll be posted.
Okay, great. And then my second question was regarding the nets. You had mentioned that for some kids they're still still challenging, but less challenging than other applications.
Right.
From the child's perspective, how do they work? What is that experience?
It feels basically like wearing a swim cap.
Okay.
It's elasticy, it's tight, it's not painful at all, and there are sponges under each of the electrode sensors, and the whole thing has been soaked in warm water. So it's a little bit wet on the scalp, warm, and tight to the head. And yes, I have a whole presentation on what we do to prep kids and practice and sort of increase our success in collecting this data.
Does it attach with a collar or something on the neck?
Yeah, a whole bunch of cords come out of the back of it. Like, pretend my hair is all the cords, and then that all goes out to the computer, or to the amplifier. Yeah. Yes?
Are there any studies or suggestions on which program for AAC would be more effective?
You mean of all the millions of softwares that are available?
Are there millions?
There are millions. People have their favorites for sure. There are the really common ones like Proloquo that are going to run you a few $100s, and there are a few of those. In my experience, Proloquo is the most commonly used program, so if parents are looking to spend that kind of money, I usually recommend you might as well go with the program that most professionals feel comfortable with, not because I think that program is any better, just because you'll get less pushback if people are familiar with it. But there are a whole bunch, if parents are just wanting to try it out at home and their child is really a beginning communicator, there are quite a lot of programs that are like $10, $15 that do just the basic functionality. And as far as I can tell, I've downloaded and tried a million of them. There's not really much difference across them. So when I see families in clinic, I usually give them a list of, like, here are some programs that I personally have seen and think are fine. I'm sure there are many more that are also fine. There's not, to my knowledge, any systematic research comparing them. I think they're much more similar than they are different.
And then just FYI, during the month of autism awareness, the programs do a 50% off.
Yes. So if you're thinking about making a serious investment in one of these programs, it's a few $100s. Wait for, unfortunately, now you have to wait for October. But it's October, right?
April.
They were just doing it in October, too. Maybe they do it twice a year
I
now.
think there's a week in October.
A week in October. Oh, it's maybe like disability awareness.
Right, yeah. I think
Yes.
there is something in October, but the month is April.
Okay,
Yeah.
April. Wait for April. Yes.
It just occurred to me as you were talking, is it likely, given the AAC, and that the speech pathologist is reducing the actual therapy during the therapy session? I'm not sure. It just occurred to me, this thought.
I think that in terms of the professionals who work with AAC, AAC devices have landed in the domain of speech pathology, but I think not all speech pathologists are prepared to work with them. And so I think, families have to make sure that they're finding a professional who is familiar with these systems and knows how to use them effectively. Same thing in a school setting. Some speech therapists, I used to be a teacher, worked in the school setting, and I first learned all this stuff from the speech pathologists that I worked with, who were incredible at working with these devices, and that's why I got interested in them in the first place. But other speech pathologists don't have much experience with them, really focus on the production of spoken language, and don't exactly know what to do when the kid shows up to session with these things. Just want to make sure no one else who hasn't asked a question yet. Any other questions? Okay, yes.
Excuse me, it might be a little lengthy question, so I apologize, but when you're introducing the AAC to the children, because my son, he has a therapist that he uses, but there's a lot of people who believe in using core words. So what is, like, do you know, like, what is your recommendation on, like, introducing?
My personal opinion is that I don't think core words are a great idea for our population. How many, raise your hand if you have any idea what I'm talking about, core words. Okay, maybe if there are no other questions, you're welcome to listen to my answer, but I don't want everyone to feel trapped here. So we can call at the end and then I'll talk shop with those of you who want to stay and hear my opinions. Thank you guys.